What would you say are some of the biggest myths about diabetes management that keep people stuck downstream?
One of the myths that we always hear, diabetes is always progressive, that it's always going to continue. Not necessarily. We can achieve remission. We can do things to put a stop to it so it won't be progressive. Myth number two, people often think that the diabetes equation involves only carbohydrates. Carbs matter, but diabetes is a result of metabolic overload. And we are talking about type 2 diabetes here. It's a matter of metabolic overload, which involves many things like stress, physiology, our sleep, inflammation from other causes, visceral fat, or the fat that we have around the organs, in the liver, around the pancreas, in the muscle. And all the factors that change the insulin sensitivity all contribute to development of diabetes. People think diabetes is a sugar problem. It's not just a sugar problem, it's more than that. If you don't have enough muscle mass, your metabolic capacity goes low and you cannot use carbohydrates as fuel. If you have sink where the faucet is on and the water is overflowing and you constantly keep mopping the floor, you're not going to stop the overflowing. That'll continue. We give drug for number. If your A1C is at this level, we should use this medication. You should limit your diet to this many carbohydrates. So people are very number centric and they are used to that. But diabetes is not a number problem only. Like I mentioned earlier, it's a systems problem. If you only change the carbohydrates and your sleep is still broken, and if your stress is still chronic and cortisol is still high and the body stays in an alarm state, giving you medications is just putting Band-Aid.
Welcome back to Lower the Dose Season 1, Diabetes and Metabolic Wellness. In our last few episodes, we talked about the early warning signs, those check engine lights, and how stress, sleep, and hormones can really silently shape your blood sugar. Today, we're talking about what it really means to go upstream, to stop chasing symptoms downstream and instead find the source of the river. So Dr. Rangi often says that true prevention means thinking like a detective. So today we'll dive into what that looks like when it really comes to diabetes. So Dr. Rangi, I'm so excited to be here with you. Nice to talk to you again. How are you today?
I'm doing great, Layla. Good to see you again.
Awesome. So let's dive in. So when people often get diagnosed with diabetes, why do you think most people get diagnosed only after years of hidden damage, even when or if they've already had checkup?
Layla, that's a great question. We wait for the disease to happen. We don't do early diagnosis and we don't use the markers in the beginning stage. We know that it takes years to develop diabetes. Diabetes doesn't just show up overnight. In major long-term study, the changes in glucose trajectory or how the glucose changes over time and the metabolic function were detectable up to 13 years before the diagnosis. And the steepest rise or the change that we see happens in the previous 4 to 5 years or so, or the few years right before the diabetes diagnosis happens. So basically, as a detective, we have to understand when are these changes that are happening 13 years ago or previously happening, and how can we detect them earlier on so we don't wait for that traditional testing that happens that diagnoses people with diabetes. Because by that time, we are too late in the game. And we should have worked on it earlier so we could have either prevented or reversed the damage before happening. So in my practice, what I believe is fasting glucose, hemoglobin A1C that we talk about, these are late markers. These can stay normal while the body is trying to compensate. And in spite of high insulin levels for a long time, that happens in insulin resistance. So our body's going to try to keep normal blood sugars for as long as possible until it just cannot. The data shows that metabolic changes long before diagnosis that happen, we can catch those earlier. So that's why we should not wait for traditional markers to diagnose somebody with diabetes. There's many people out there who are not even diagnosed with diabetes and they have diabetes. And a lot of people are not diagnosed with pre-diabetes. So that means we're waiting for them to get diagnosed.
Absolutely. And I think when it comes to diabetes, there's a lot of myths that surround diabetes and diabetes management. So, what would you say are some of the biggest myths about diabetes management that keep people stuck downstream?
One of the myths that we always hear and that even we practiced 20 years ago when I started practicing medicine was diabetes is always progressive, that it's always going to continue. Not necessarily. We can achieve remission. We can do things to put a stop to it so it won't be progressive. And remission is achievable in many people, especially when we work with them earlier on. And that's not hype. There are trials that have been done that show that we can clearly bring these people in a meaningful remission rates with intensive weight loss or intensive changes in their lifestyle, especially if we work with them earlier on in the first 5 to 6 years of their diagnosis. So that's myth number one, that diabetes is always progressive. Myth number two, people often think that the diabetes equation involves only carbohydrates. Carbs matter, but diabetes is a result of metabolic overload. And we are talking about type 2 diabetes here. It's a matter of metabolic overload, which involves many things like stress, physiology, our sleep, inflammation from other causes, visceral fat, or the fat that we have around the organs, in the liver, around the pancreas, in the muscle, and all the factors that change the insulin sensitivity all contribute to development of diabetes. So it's not just the carbohydrate problem, it's the metabolic overload problem that happens because of various reasons that I mentioned. People often think if my blood sugar is okay, then my diabetes is under control. And that's where I spend the most time telling them how their duration of diabetes over time and how well controlled or not controlled they are, all that determines if they are at a higher risk for complications. So when I talk about thinking upstream or thinking ahead, it is more to look at the bigger picture, not just a blood sugar problem or the glucose problem. That's the myth. People think diabetes is a sugar problem. It's not just a sugar problem, it's more than that.
Absolutely. As someone like myself, I'm not the most well versed when it comes to diabetes, but going off what you're saying about myths, that's my understanding of it as well. I feel like I learned so much about it when I speak to you because, like you said, most people tend to think it is a carb, sugar intake issue that is, that's where diabetes usually stems from. So it's so interesting to learn that it's a lot more than that. And you mentioned go upstream. So when you say go upstream, what does that mean exactly in practical terms?
Yeah, Layla, I created a course called the Upstream Diabetes, and I did talk to few of my colleagues, and they also mentioned that patients may not understand what upstream means. So thank you for asking that question. If there are floods coming, you're going to stop the river where it's coming from. You're going to stop the overflow that is happening. That's exactly what upstream means. That means we're working on the underlying root cause of the problem, and that is insulin resistance, visceral fat, addressing other causes like sleep deprivation or chronic stress that is increasing the cortisol patterns or body's hormone imbalance. Inflammation happening for many reasons. It could be the diet, nutrition. It could be the way we are treating our lifestyle, the kind of snacks we are choosing, the kind of choices we are making. Also, if you have enough muscle mass or not. If you don't have enough muscle mass, your metabolic capacity goes low and you cannot use carbohydrates as fuel. So your blood sugar rises, and that has tendency to accumulate in your liver as well to store the energy. So when we talk about upstream, it's basically talking about rise in blood sugar is end result problem. If you continue to mop that, if you have a sink where the faucet is on and the water is overflowing, and you constantly keep mopping the floor, you're not going to stop the overflowing. That'll continue. So you need to use whatever plan that you use to help with the condition by stopping the faucet, not constantly mopping the floor. I hope that answers the question.
Absolutely, that's such a great analogy. And speaking about the root cause, so you've created a structured approach that really helps people identify and fix the root causes of blood sugar imbalance. So, what are those key root areas? I know insulin resistance, I believe, is one, but what are some of the others?
Yeah. Um, so Leila, we like to use the upstream framework in different scenarios. One is when the patients come to us, we like to look at things in a way where we can understand all the pathophysiology or all the reasons or the root causes that probably could be contributing to their high blood sugars. The other thing is I really believe in awareness. So as soon as the patients come see us, we want them to understand as much as possible about their condition. So I have created this course called Upstream Diabetes. That is something that is very helpful to my patients who can understand what does having diabetes mean? How can they take care of their body? How can you reverse it? What does pre-diabetes mean? How many people with pre-diabetes end up developing diabetes? How can I take care of my heart health? How can I have a normal life with no problems with my relationships? Because diabetes is, again, not just a blood sugar problem. So we have to work around and help them live a normal life, how the fertility can be affected, how it can affect your intimacy, and of course we talked about heart health and other things. So we educate patients with our upstream diabetes course. So that is one thing that we use, and then we address the root cause while evaluating them. So we definitely look at what's contributing to their insulin resistance, what is contributing to their chronic stress physiology that is increasing their cortisol levels, and that cortisol is pushing their glucose higher and even driving their cravings. A lot of people, um, a lot of my patients, they end up staying up at night, and that's a time when they get more cravings and they tend to snack more. And that adds to the problem, that fuels the fire. And then we also talk about inflammation as another driver that contributes to the end result of diabetes. So there's kind of a smoldering fire, that, if I can say that, that worsens the insulin signaling. So what is contributing to the inflammation, and if we can reverse that, that can help us improve the insulin signaling, and that can improve the glucose metabolism. And in some cases, like I mentioned, muscle is your biggest glucose disposal organ. And if you have muscle loss, or if you don't have, if you have poor muscle mass to begin with, um, in some cases, we see nutrient deficiencies. For example, if you have vitamin D deficiency, your insulin signaling does not work well. You have more insulin resistance. For example, vitamin B12 deficiency, we see that a lot in people on metformin. In some cases, certain medications lead to magnesium deficiency. So we always want to look at what could be contributing to either person's symptoms, which could be even nerve damage that is causing their numbness, tingling in their feet. So it's not just sugar problem. We work with upstream philosophy at every level that we can to help people stay healthy as long as possible and to prevent complications from happening. And if they have the complications, then what else can we do rather than keep putting Band-Aid on those?
Absolutely. It's so interesting to really hear and learn about how all those things come together, because I feel a lot of those are more common than people realize, and without really realizing how much it can lead to diabetes. For example, vitamin um, D deficiency, or I know, like you said, with metformin, B12 deficiency. And I know a lot of times B12 is prescribed with metformin and GLPs and medications like that. So it's interesting from my end to really learn how all of those things actually fit together. And why do you think that so many people focus on food or medication alone when the real issue, as you said, is metabolic overload?
Because that's the standard model that we have. You know, That's a traditional medicine. And that's why I always say for you to get in the best health, you should be ready to step outside the traditional health system because our system is set up for that. We pretty much look for a pill for every ill, or we patients expect that too. A lot of times they'll say, "Oh well, my A1C is high. I didn't come to you just to understand how I can eat better and move better. I want to know what is the right medication for me." So we need to change that mindset that when we're trying to address multiple upstream factors, just putting somebody on a medication is not the answer. We give drug for number. You know, if your A1C is at this level, we should use this medication. Um, you know, you should limit your diet to this many carbohydrates. So people are very number centric and they are used to that. But diabetes is not a number problem only, like I mentioned earlier. It's a systems problem. If you only change the carbohydrates and your sleep is still broken, and if your stress is still chronic and cortisol is still high, and the body stays in an alarm state, um, giving you medications is just putting band-aid. When multiple upstream factors stack up, they lead to the problem that is, we call it a pleiotropic. So we have to either work on the root cause that is contributing to it, you know, so we work on improving the sleep hygiene, improving stress management, teaching the tools. We look at where the visceral fat is. We do body composition analysis so we understand how much of fat is in the liver, try to target that, improve muscle mass by increasing more weight bearing or strength exercises training. Um, yeah, you get metabolic overload, but we need to address the whole spectrum of metabolic overload and not just treat one medication to get the number down. We got to address the stack and not just one piece.
And what happens when someone starts addressing multiple upstream factors instead of just counting carbs?
You know, we offer a lifestyle program in our practice, and we have people whom we put on a certain lifestyle changes, including addressing their nutrition, their movement or their exercise. We offer a healing hour where we offer, you know, strength training and cardio exercises twice a week. We also offer stress management. So when we use all these different modalities to help people, what we see is they often feel the relief very quickly. It doesn't take too long. The cravings settle. The energy improves. The fasting glucose tends to go down. Their A1C starts to come down, or their glucose control starts to improve. And in fact, I see myself taking them off of medications. We have taken so many people off of insulin. We've taken so many people off of so many medications that once we work on the root cause or the upstream methodology, then people don't get dependent on these chemicals anymore. They don't need the prescriptions. And here's what is really important. The best outcomes tend to come from these multimodal approaches, like I mentioned, not one hack. We cannot tell you, do this. Yeah, so, you know, for us to bring diabetes in remission, we got to work with people earlier on. And even if you're late, we can definitely work with the lifestyle, and that can improve you to get off of medications and improve your risk of, lower the risk of complications, lower the dose of prescriptions, lower the number of prescriptions, and overall feel a lot more energetic.
That's incredible. And for someone listening who's been told over and over or for years that you'll always be diabetic, what would you tell them?
Yeah, I would say you've been given a story that isn't always true. The clinical term we use now is called remission, um, not reversal, because remission is real, but it also acknowledges diabetes can reoccur if the old patterns return. So I often tell folks when they work with us that we can do our best to help you come in remission. To say that we have reversed your diabetes is not the right thing. Maybe in somebody who's earlier on in the metabolic journey, when they have not developed prediabetes yet, yes, we can reverse. Or once they have not developed diabetes, that is the early stages when we can reverse. But at this time, we can, anybody at any stage of diabetes, we can do our best to modify the lifestyle and address the, like I said, the multimodal approaches to bring someone in remission. It's how we define remission is it's the sustained normal range of glucose below the diabetes threshold for at least 3 months without glucose lowering medications. So not everybody who can work with us can go into remission, but you can certainly try to work with your doctor or somebody who believes in helping you either bring in remission or help you get so metabolically healthy that you don't need as many medications. So I would just give them hope. That's not correct that once you're diabetic, you'll always be diabetic.
Absolutely. I think that's so important for people to hear. And how quickly would you say that people see improvements once they start applying these upstream principles?
It's faster than most people expect. Some see fasting numbers improve within weeks, and especially as the sleep improves, as the liver becomes less insulin resistant, the A1C reflects 2 to 3 months average. So that typically lags. So we may not be able to see the A1C changes. But I often have people wear their continuous glucose monitors, and I tend to see them once we apply these lifestyle principles. We see them every month and sometimes every couple weeks. And I see myself taking them down on the amount of insulin, down on the amount of medications every 2 to 4 weeks. And by the time we repeat the A1C, of course, it shows much improvement. But even during the continuous glucose monitor that we download, it shows much improved time in range. Time in range is the new A1C, so we call. We want anybody's time in range or in a good control of diabetes more than 70% of the time in a day. N- And it's very possible to start seeing those changes within a couple of weeks or within few weeks. And earlier the diagnosis, the higher the remission potential or higher the chances, because your beta cells are the cells that function, that make insulin, are often more preserved. The longer you wait, the beta cells tend to either not work well or they get destroyed over time. So you have less beta cell mass in people who have long-term diabetes. So yeah, we see the changes pretty quickly, and depends on how far somebody's in the journey. If they're earlier on in the journey, then we see more drastic changes faster.
Absolutely. And if someone wants to start thinking upstream today, what's the first step you would recommend for them?
Um, Number one is get the clarity. Look beyond A1C. A1C is your goal that you've been given by your doctors. How I like to look at upstream is we need to look at what is the bigger picture. We know people with diabetes tend to get more heart attack, more stroke. They can tend to get more vision problems. They get more kidney problems. So my approach is step one is get the clarity. A1C is just one of the things you're looking at. Your overall goal should be, if you have type 1 diabetes, try to optimize your lifestyle so much that you need least number of medications. The number of medications that you need to be absolutely be on, those should be doing something more than what just lowering the blood sugars. Because diabetes is not just a blood sugar problem, it's more of cardiometabolic problem. So we definitely want to use medications that are available nowadays that improve cardiometabolic outcomes. In other words, they are diabetes medications, but they help prevent heart attack and stroke. So work with your doctors, understand what your A1C goal is. Ask them, what can I do to improve my lifestyle? How can I be on the least number of medications? How can I make sure I'm not on any medication that is just lowering my blood sugar, but also helping protect my liver, protect my heart, and protect my kidney? And of course, the end result will be protecting your brain and vision as well. Um, So that's number one, get the clarity, and then pick the simple upstream move you can sustain. You may not be able to work on everything all together. If you can work with someone where they can offer a combined program that can help you work on your sleep, your diet, nutrition, your overall well-being, fantastic. But if you're not able to work with someone where you have that kind of a program that can help you address the multimodal approach, then you pick one thing at a time. It could be you start working on sleep, first of all, that I have to have my sleep hygiene. I got to not be on the bright lights. I got to make sure I sleep 7 to 8 hours. Once you master that and you start sleeping well, you will see you have so much more energy. And then you will make sure that you start getting 150 minutes of exercise a week. And then you start building on your nutrition. So start working on the list of things that you should do to improve your health, than just going and showing up at doctor's office every 3 months with just an A1C.
Absolutely. And you've mentioned the program you've created, the Upstream Diabetes course. So, being that you've created that program that really walks people through this exact process, can you explain a little bit about how it works?
Yeah, so the Upstream Diabetes course is something that anybody can purchase. You don't have to be our patient for that. And this has different modules that explain you how you can change your lifestyle. What are the things you can do to prevent complications of diabetes? What is prediabetes? How can you prevent progressing to diabetes? And if you have diabetes, what are the overall picture look like? What do you need to be um, I call this as be self advocate. You've got to understand what things are going to help you ask the right questions to your doctors and how you can self help yourself. So I think that program can be very instrumental for anybody with diabetes or prediabetes, or even if you're a caregiver for somebody with diabetes. And if you didn't know how to take care of yourself, then this can help you, optimize your care and work with your doctors to get the right care and get the right medications. We even discussed all the latest options of medications. What are cardioprotective medications? What are the medications you should be on? So I think it's one-stop shop for you to understand how to take care of yourself if you have diabetes.
Absolutely. And with this, what kind of results can participants expect? And what makes this approach different from standard diet plans or standard coaching?
Leila, the evidence is very clear. Weight loss is the strongest predictor of remission. So there's definitely that is what we're looking at. A dose response relationship has been shown that the degree of weight loss and the likelihood of remission. So with our lifestyle program that we offer with coaching in the office, we try to get at least 10 to 20% of weight loss if we can. If not 20, definitely 10. And if possible, anything more than 10%. So the studies have clearly shown all you need is 5 to 7% of body weight loss to improve your metabolic outcomes. So certainly weight loss is one of the important factors that we're looking at, and that helps you go into remission. The more weight loss you have, sooner you have it, the more likelihood of remission and less likelihood of relapse. So more likelihood that you probably can stay in remission and avoid diabetes from coming back. But relapse is common if the weight gain reoccurs. So participants can expect when they work with us that we're going to help them improve their nutrition, help them make the right choices, help them with meal planning, help them with, grocery shopping and, get them the right list, work with a nutritionist. We also have a wellness coach who can work with them. We have a movement and meditation coach who works with them. So we have a complete package that we offer. So most important metabolic change happens when the weight loss happens. But with our program, we help with decreasing the stress, improving the sleep, improving your mental health, improving your physical health by working with the movement coach and the strength training. So yes, they can expect all those results, and the end result is all that is going to help them improve their diabetes control. And improved diabetes control means they will need much less medications, lowering the dose of their number of prescriptions, lowering the dose of their prescriptions that they're taking, and hopefully a lot of them will get off of a lot of medications.
It's incredible. And why do you believe every person, even those already diagnosed, should still aim for an upstream prevention?
Because the diagnosis is in the end. It's a beginning of a choice. And once you're diabetic, that doesn't mean that we got to just control your diabetes, as I mentioned earlier. They need to constantly think, now that I have diabetes, now that I'm on the right track, what else can I do to prevent that first heart attack? What else can I do to prevent dementia? What else? Repeated hypoglycemia or low blood sugars can increase the risk of cardiac outcomes, or increase the risk of heart attack, and increase the risk of forgetfulness or dementia. So we got to be on the right treatment path where our intense control should not worsen the outcomes. And also, if you're not getting any low blood sugars or any complications, then also what else can I do so I am not at a higher risk for heart attack, as we expect all people with diabetes. So we may have to work with, some other factors that might be contributing. So at every level, you got to think upstream, because our end result is to improve and preserve the quality of life, keep our independence, less dependence on other people to take care of us in our older age, and be on least number of prescriptions, and not only just have longevity, but also have vitality in our life, and be as, keep our hormones in good check and balance and optimize them, so you can have life full of experiences, and you're not just having barely checking off the numbers at the end of, your visit.
Absolutely. I think everyone wants to keep their independence as they age and live a life full of vitality. So, thank you so much for sharing that information. And Dr. Rangi, I think that this was powerful because going upstream isn't just a medical idea, it's a mindset shift. So, if today's episode resonated with you at all and you're ready to stop guessing and start reversing your risk, check out Dr. Rangi's Upstream Diabetes course. It's a self paced, doctor designed roadmap that helps you understand your numbers, reset your metabolism, and finally take charge of your health. You can learn more or enroll at go.rangimd.com/join. The link is going to be in the show notes. So make sure to look out for that. And remember, the best way to lower your dose of stress, sugar, and crisis is to go upstream. This is Lower the Dose, and we'll see you next time. Thank you again, Dr. Rangi. Cannot wait to talk to you soon.